Recently, the Society for Vascular Surgery has decided to sponsor an audiovisual archive to feature the outstanding leaders and contributors in vascular surgery. A committee consisting of Jimmy Hour, Norm Rich, Cal Ernst, and me was formed to undertake interviews of our most famous and distinguished colleagues. My name is Roger Gregory, and today I will be conducting an interview with the legendary surgeon, Dr. Denton Cooley, at the Texas Heart Institute. Dr. Cooley, thank you for agreeing to do this interview.
My pleasure to have you here.
Dr. Cooley, you were a third-generation Houstonian, is that right?
That's true, yeah. My father moved here in 1890 with 3 sons. He started a big real estate development out here north of Houston called the Houston Heights. They call it the Heights because it was 20 feet higher than downtown Houston, which was more of a swamp at the time. But he was considered the father of the Houston Heights.
But I thought he was a prominent dentist.
My dad was a dentist. This is my grandfather.
Oh, your grandfather, okay. Yeah. And your early education was through the public schools?
Yes.
Rather than a
schools.
Private education. You went to the University of Texas for college, graduating in 1941. During that time, you were on the varsity basketball team as well.
Yes.
Playing forward or center?
Or? Forward, and I was the second tallest man on the team, so sometimes I played center, but most of the time forward.
You also played tennis and golf, and I don't know how you had time for a major in zoology.
Well, I don't know.
Tough major.
I always said it's a challenge when you're in college to budget your time, and you can find time to study and mix in social activities, for fraternity life and that sort of thing, but you have to first pay attention to your studies and your grades.
When did you learn music, or when did you get involved in music?
Well, like most young people, their mothers want you to play the piano, some other instrument, but my mother was a pianist, and she was determined that I would become accomplished in piano, but my hands were sort of crippled up from playing sports and baseball and basketball, and I finally had to give up piano.
But you learned the basics of
yes.
music at that time. For medical school, you started at the University of Texas, but moved to Hopkins. Why did you happen to move?
Well, the most prestigious medical school when I graduated from the university was the medical branch in Galveston. It's the oldest medical school in Texas and the most prestigious. And I went to there from college, and after about a year, they were having, it was just before the war, and they were having some conflicts in the faculty, between the faculty and the dean's office and so forth, and they made a lot of publicity, and I got concerned that maybe the medical school would go on probation. So I looked around and decided maybe I would quietly transfer to another school. I'd already spent about 6 years in the University of Texas schools. I thought maybe I ought to sample some others.
Yeah, you moved to Johns Hopkins, where you graduated in 1944, and started a residency at that time under Dr. Blaylock, and in fact assisted on the first blue baby operation, so-called Blaylock-Tarsic. What was that like to be in such a historic moment, and what was Dr. Blaylock like?
Well, he was what I would call a true Southern gentleman, just a wonderful man, and very compassionate with his patients, and very considerate of his house staff and so forth. And he was just a good person, and I enjoyed knowing him. I was fortunate to meet him one time unexpectedly when I was began my service there at the Johns Hopkins. I was cutting his big clinic one Friday, and I was out playing tennis with a friend of mine named Lester Persky. Dr. Blaylock was walking across the compound there with his staff, which was Bill Longmire and Mark Ravitch and Harry Muller, and I thought, well, told Lester, I said, you know, I think we're going to send us back to where we came from. Lester had just moved from the University of Michigan, and I came up from Texas. On the contrary, Dr. Blaylock came back out of the Harriet Lane home where he'd been visiting with Dr. Taussig. He came out and watched a few games of tennis. He called me over and said, Mr. Cooley, come over here, please. I went over there. I said, well, here I go. And he said, Mr. Cooley, you play a pretty good game of tennis. Do you know how to play ping pong? And I said, yes, sir. He said, well, Ms. Blaylock and I are taking our family down to Gibson Island, which is on the bay shore there, and I need somebody to play ping pong with me. I couldn't believe it. But sure enough, I got to spend the weekend with Dr. Blaylock and his family down at Gibson Island in Bill Reenhoff's house there. And it was just an unusual opportunity for me to meet this man and to know what a wonderful person he was.
What was the first operation like, the first Blaylock? Well,
you know, there's a lot of concern around the hospital because in the first place, nobody thought one of these little critically ill children with intense cyanosis could withstand anesthesia, particularly inhalation anesthesia. So it was a hard time deciding who would give the anesthesia for that little child, little Saxon girl. And finally, the chief of anesthesia, the new chief we had there, declined the invitation, and one of his residents gave the anesthesia.
Wow.
A guy named Merrill Harmel, who later became well known as an anesthesiologist. But sure enough, he was capable of putting the child to asleep, as we said, and proceeded with the operation.
Do you remember precisely what clamps were used, or what the exposure was, or was anything? I know you were not the first assistant on this case.
No, I was an intern down at the foot of the table.
Could you see what was?
Not much, I could not, but I could see Dr. Blaylock and listen to him whining and so on. He had this tendency to whine during his operation, and he said, won't somebody help me, give me some exposure, that sort of thing. But standing behind Dr. Blaylock was Vivian Thomas, this African-American man. Vivian became famous in his own right because he ran our laboratory, the animal laboratory and everything. But Dr. Blaylock was so humble, every now and then he'd say, Vivian, do you think I'm doing this properly? You know, that sort of thing. At that time, it was unusual for a black person to be invited to be part of the team, even to be an observer. But
made it even more spectacular in retrospect.
Yeah.
Don't you think?
Oh, yes, indeed.
Now, you went into military service in the middle of your residency, going to Germany from 1946 to 1948. But then a highlight in your life came to pass in that you got married in 1949.
Yes, that's when I returned from military years. I met Louise Thomas, and we got married within a few months after that.
You went back to Hopkins to complete your residency and finished in 1950, at which time you decided to spend time with Mr. Russell Brock, later Lord Brock, although this was primarily a year in which you had addressed the management of TB. He was also involved in valvular procedures and certain congenital heart problems. What was that year like, and what was Dr. Brock like?
Well, he was an interesting personality. He was a very stern sort of an individual, didn't have a big sense of humor, and wasn't as congenial as Blaylock was. I was disappointed that he didn't have some of those qualities. But he was a very determined surgeon. He wasn't a really skillful surgeon, but he was determined, and he would get an operation done regardless of the difficulties. But I enjoyed very much being there, and I was inspired by Russell Brock, who was the most prominent surgeon, I thought, certainly in thoracic surgery in the United Kingdom. And I can remember him very well. He was the president of the Royal College of Surgeons of England at the time. And one day I came back and I told Mr. Brock that I had been down to Lincoln's Inn Field down at the college and wanted to become a fellow of the Royal College of Surgeons. I thought that was elegant to have FRCS behind your name. Mm-hmm. And Mr. Brock said, Cooley said, don't study for the examination. It's beneath you. Concentrate on getting it honorary. So after 30 years of concentration, I received fellowship honorary.
Did that time, when you look back, do you think that's what sparked your interest in pediatric heart issues?
Well, of course, the initial exposure there in November of 1944 with Blaylock and Taussig, and then the Blue Baby era that followed that, in which I became Dr. Blaylock's first assistant, that certainly inspired me. I thought the congenital anomalies were the challenge that would see more progress in the future than acquired vascular disease.
Now, you returned to Houston in 1951. Why Houston? Why did you want to come back?
Well, I'm a native Houstonian, you know, and most Texans want to go back to their home state, and especially if the home state is Texas. But anyway, I was interested in coming back to Houston primarily because we were starting the Texas Medical Center. And really the founder, I think, of the medical center was a man named Burtner, E.W. Burtner, who had influenced me to go to Johns Hopkins for my medical education because he had some years at Hopkins himself. Mm-hmm. And he was also my mother's obstetrician, so he was the first man to lay eyes on me. But all those things influenced me, and my dad and my mother and everybody living in Houston. And I thought it was a wonderful opportunity for me to go back to my hometown and participate in the development of the Texas Medical Center.
You joined the Baylor Department of Surgery at that time. What were the early days like in the department and with Dr. DeBakey?
Well, I had contacted Dr. DeBakey even before I went to London, and he encouraged me to go ahead and take that year in London. But at the end of that year, I had a position on the faculty at Baylor. And when I came back to Houston, Mike DeBakey told me he wanted me to start a real department or interest in cardiovascular surgery. And on the staff at the time, our young members of the surgical service, not many of them had any experience in cardiovascular surgery at the time. Perhaps the only one that I remember who was a good surgeon named Oscar Creech.
Yes.
And Oscar was a very interesting personality in vascular surgery particularly. But that was the way it was here. We were not, the hospitals where we became very active did not open until 1954. So Dr. DeBakey and I operated over at the City County Hospital, the old Jefferson Davis Hospital, sometime over at the Herman Hospital, which had been there for a while, but the Methodist Hospital, St. Luke's, and Texas Children's Hospital, all three opened in 1954, 3 years after I returned to Houston.
Now, during this time, and when you moved formally to St. Luke's in 1960, during this time, a certain amount of rivalry and conflict arose between you and Dr. DeBakey. When you look back, what was that about, and how do you see that now?
Well, Mike was a very determined, ambitious person, a hard-working man, and he wanted to not only promote Baylor, but wanted to promote his own status. And sooner or later, we began to have some conflict. Dr. DeBakey might hear that I'd removed an aortic aneurysm over at the Jefferson Davis Hospital. That probably upset him to some extent because I hadn't called upon him for advice in those early days. So one thing after another, Mike and I began a bit of a rivalry.
Well, in 1962, you founded the Texas Heart Institute, and you'd have to say the rest is history. Looking back, why were you so different from hundreds of other cardiovascular surgeons that were arising at that time? What are your thoughts on why this happened?
Well, it's kind of difficult to explain on that. I don't want to say that I considered myself a naturally gifted technician and so on, but I thought that in general that my experience with some of the operations I had done independent of DeBakey and aortic aneurysms and so forth made me confident that this was a new era and that we ought to be more aggressive as surgeons than previous generations.
But I have to say, so that this doesn't sound immodest for you to say, but you were always considered the most technically gifted surgeon in the world.
Yeah, sometimes that's a sort of a limited compliment. It seemed almost like I was decerebrate. I'm never credited with being the most brilliant or the most knowledgeable.
Well, this was clearly at a time that new ground was being broken and a pioneering era for cardiac surgery with development of the pump and better techniques, better anesthesia, and better surgeons with better minds.
You know, once we got involved in these things, in vascular surgery and cardiac surgery, almost every case we did was a reportable case. You know, you didn't have to have a series, it's just a case report, and that would be sufficient.
Yeah, some of your highlights, besides thousands of operations with excellent results, 1,300 scientific articles, 12 books, the Medal of Freedom from President Reagan, the René Lariche Prize, the National Medal of Technology from President Clinton. One of the biggest highlights was the 1962 text on congenital heart surgery. This is a startling landmark, would you say?
Well, I thought so at the time. It's not a great big textbook, but it's about a 200-page book.
But it gathered together everything until that time.
Yeah, it gives a state of the art in cardiac surgery then. It's a beautifully illustrated book. We had a really gifted medical artist named Bill Andrews, who was probably the best pen and ink artist in the world at the time.
In 1968, you did the first successful cardiac transplant in the United States. But in 1969, you did the first artificial heart operation with this photo showing your the artificial heart removed and being replaced with a...
Yeah, that's the artificial heart. It had been in place for about 3 days, and then we had this donor heart that came on. We just we really had only planned to use this artificial heart as a bridge
Right.
to transplantation.
This is a very startling event, which I think is safe to say took the world by storm.
Well, I think so. I'm glad I had the courage or the stupidity to go ahead and do it.
Now, as spectacular as your career in cardiac surgery has been, your many achievements in vascular surgery are frequently minimized or ignored. Your long-term achievements in aortic surgery is of very great interest. And in one article, you said that throughout your career, at least 20% was involved in peripheral vascular surgery, particularly aortic surgery. Obviously, this is where we'd like this discussion there to focus. One of your first operations at Baylor in 1951 was a resection of an ascending thoracic aortic aneurysm at old Jeff Davis Hospital. What do you remember some of the?
Well, that was one of the interesting events of my career. I just returned to Houston and I was on the faculty as an instructor at Baylor, and Dr. Blaylock, no, Dr. DeBakey, I keep saying Blaylock when I'm at DeBakey. Well, Dr. DeBakey was making rounds, and we had this African-American guy named Joe Mitchell who had a lytic aneurysm in his ascending aorta, and it was bulging out through the chest here. And you can see the pulsations like that. And Dr. DeBakey said to the staff, said, well, we have a new member here of our staff. Dr. Cooley, what would you do to that aneurysm? And he expected me to say I'd put some wire in it or try to cover it with cellophane. And I said, well, I think I would just excise the aneurysm. He said, well, you want to try to do that? And I said, yes, sir. And I said, well, you do it tomorrow morning if you want. So I had the operation all lined up. I had to go across town to get one of those old Lebsche chisels to open the sternum. And that was over at the Veterans Hospital, and I drove back over to Jefferson Davis, and about 9 o'clock, Dr. Blaylock, I said it again, Mike DeBakey walked in, and he went over to the scrub sink, getting ready to scrub his hand, and he said, he looked over my shoulder and said, well, what are you doing here? He said, well, that aneurysm, Dr. DeBakey. I said, there it is over there in the specimen basin. And I was sewing up the aorta. Had a big clamp on the ascending aorta at the time, and that was, I think, the first time that he really appreciated the fact that we could operate directly on the aorta.
Did you use a homograft or a homograph?
No, this is a sacciform aneurysm.
Oh, okay.
And so it was good. We could do what we call tangential excision and repair.
Now, the clamps back then, atraumatic clamps were not available at that time.
No,
what did you use?
Well, they did have clamps. You know, you had to select one that wouldn't cut through the aorta, but we modified them later on to have a longer ratchet so you could close it just as much as you needed to occlude the vessel without tearing the aorta. But
well, that was certainly you were one of the first people to tackle an aortic aneurysm.
yeah.
Now, there have also been reports that you did the first carotid endarterectomy.
That's true.
Now, when was that?
Well, that must have been 1956, somewhere in there, 55. And we had a patient who came in, and his complaint was he couldn't sleep at night because he heard this swishing noise, the bruit, on his left side of his head. And we decided that maybe we could clean out that artery and get rid of the swishing sound and prevent him from having a stroke. So me and my colleagues, younger guys, both of them, did the operation and removed this aneurysm there and did an endarterectomy, and we're using a transverse incision in the terminal common carotid artery, and cleaned it out. And of course we were worried about the man who didn't know what clamping the internal carotid artery, what effect that would have on the brain. And sure enough, even though we clamped the carotid artery only for about 15 minutes, the patient did wake up with some weakness in his right side. Fortunately, in the next 10 days, that weakness disappeared. But that was, he got rid of the bruit in him.
Now, DuBose is always attributed with doing the first aneurysm in 1951 in March 29th. But March the 2nd of that same year, Schaefer and Hardin did an aneurysm, resected an aneurysm, which unfortunately died on the 29th postoperative day. Therefore, it was never counted as a survival. In April the 28th of 1950, you repaired a thoracic aneurysm when Dr. Blaylock was out of town. Was that right?
Yeah, that's exactly right. Yeah, I remember that patient very well. It was a patient, we had done a repair of a coarctation about 6 weeks before that. But he developed this aneurysm here, and it was getting larger all the time. And Dr. Blaylock was in Honolulu at some sort of a visiting professorship there. And so I was the chief resident, so it befell my responsibility to take care of this patient who came in with an impending rupture of this aneurysm. And I made my incision up in here and took out this aneurysm, really of the innominate artery. It was about the size of a large orange, and this we clamped off the innominate artery and ligated the carotid and the subclavian artery. But the man had no neurologic problems from that, probably because he had coarctation with all those collateral vessels.
Right.
But anyway, Dr. Blaylock was, when he came back from his trip, he was very complimentary of the results of that operation.
Now, this is before the seed was planted in your mind to directly reconstruct. Is that what you had in mind doing when you went in on that case, or?
I did. Yeah, I did. I thought that was the only alternative, and even though I thought it might lead to this man being completely incapacitated by ligating his carotid artery, I thought it had to be done.
Now, 6 months later, you ligated a subclavian aneurysm. I don't know whether Dr. Blaylock was in town for that or out of town. Was that it? That was quite an unusual case as well.
Yeah, it was. Yeah.
As you say, every case then was reportable.
Yeah. And one thing about the Hopkins residency, you know, the senior resident there is almost independent, and you divide the hospital up into your ward patients, your clinic patients, and the private section. And the ward patients really belong to the resident staff. And Dr. Blaylock really wanted the residents to operate independently there, and the staff could consult, but did not take the case away from the resident.
In 1954, you also did the first successful ruptured abdominal aortic aneurysm, this time using a homograph.
Yes.
Was that that had to be a spectacular moment to realize that?
It really was. I was looking back on my residency at Hopkins. I can remember opening an abdomen with a patient with an acute abdominal thing, and you see all this blood out in the mesentery and so forth. And we used to call that abdominal apoplexy.
Yes, sir.
And I think all the time it was a rupturing abdominal aneurysm. But those patients never survived.
Right. There was nothing you could do at that particular time. Going back to your international training and your experience with Dr. Brock, this was such a favorable influence on you at that time Yet international training seems to be on the decline now. Foreign surgeons are having difficulty coming to the United States for training. What is your opinion on that?
Well, things have changed enormously. I think in this country we led the way in this new era of cardiovascular surgery. Previous years had been people went to Europe to learn intestinal surgery and things of that nature, and thyroid surgery. But when vascular surgery came into being, we became the leaders. And as time has gone by, we used to have a lot of residents and fellows that came here for training. But now that all of the big centers in Europe and elsewhere in the country have begun their own program, not as many come as used to be here.
Do you think the disappearance of ISCVS, the North American chapter, and the merger of SVS and ICVS, do you think that's played a role in this decrease in international exchange?
Well, I'm not sure about that. I think there's probably time for the two groups to merge and have a combined program going. But there'll always be a place, I think, for an American vascular society to identify from the European.
Recently, a push was made for an independent board of vascular surgery that was advocated by Frank Beath and many others, including myself, but was denied by the American Board of Surgery. What was your opinion of that?
Well, initially I was resistant to that change, but as time has gone by, it does seem to have a place. The unfortunate thing is that now people who are general surgeons are more or less restricted in what they can do. Right. And vascular surgery, to my mind, is just a branch of general surgery. And I think that surgeons ought to be permitted to do vascular surgery, even though, the general surgeons are going to be confined to intestinal surgery before long. And even the intestinal surgeons now want a separate board. I think they're going to divide up the specialty too, strictly.
Yeah, in 1986, you authored this atlas textbook on aortic surgery, which was, I'll have to say, one of the few atlases dedicated primarily to aortic surgery. How and why did this come to pass? And there were no co-authors. This was yours alone. How did this happen, and why did Denton Cooley, the cardiac surgeon, decide to write an atlas on aortic surgery?
Well, that's a sort of a delicate subject. At the time, Mike DeBakey was very much involved in aortic surgery, but I wanted to have a record of my interest and contributions to aortic surgery, and I thought I ought to do it separate from Mike. At the time, Mike and I had separated. He was doing all his work over at the Methodist Hospital, and I was working entirely over at St. Luke's and Texas Children's Hospital.
But you had other colleagues.
Oh yeah.
But this was written by.
Well, maybe I'm being rather immodest, egocentric in not having a co-author, but I'm not sure which of my associates at the time deserved to be a co-author.
Well, this is a spectacular work, and with extremely educational for then and now. Could you tell us a little bit about the 1949 case in which you used the muscle flap Well, the muscle patch, when you were a resident at Hopkins, this is a case that has intrigued me when I read about it. What was this about?
I'll try to be brief about the details, but this was a patient who had an osteochondroma of his manubrium, and Dr. Grant Ward, who was a surgeon there, conceived the idea of replacing the manubrium with a Vitalium prosthesis. And over the space of about 3 months, this Vitalium prosthesis eroded into the ascending aorta. So on a Saturday afternoon, sure enough, the thing burst, and we took the patient to the operating room and opened his sternum. Dr. Ward was a partially incapacitated individual. He had a syringomyelia operation and had one arm up in a permanent cast here. And I remember when we opened the sternum and this blood shot up to the operating room light, Dr. Ward took his other hand and put his finger on the hole in the ascending aorta. And I was his resident at the time. He said, "Denton, what are you going to do now for me?" I said, "Well, Dr. Ward, we cut your finger off and leave it in there, if you can spare that." And I said, "Well, why don't I just take a little piece of the pectoralis muscle and make a patch and patch the hole in the aorta?" And so I cut a piece of pectoralis muscle and slipped it in my suturing part of it around there. And I said, "Now pull your finger out." He pulled his finger out, and I pulled the sutures down and patched the ascending aorta. And I think that was one of the first operations of this kind.
What brought you to think about using a muscle flap? Just spur of the moment, or?
Well, I guess it's spur of the moment. I've forgotten just what. What would you take? Some other? Would you take a piece of skin or something?
Now, did these experiences seem to plant the seed for using a more direct approach in aortic surgery versus what had always been indirect in the past?
Right.
Is that right?
I thought surgeons ought to become more aggressive and not be so fearful of the aorta, which was one of those organs that you wouldn't want to touch at the time.
As you know, endovascular surgery has become a very prominent activity in vascular surgery now. What is your opinion of endovascular surgery?
Well, I think it's an interesting advent of a new technique of repairing these vessels from the inside. And to put what I used to call, in my old Model T Ford, we would repair the blowout or something with a boot inside of the casing. And that's what I thought that this endovascular sort of replacement and repair is like we used to fix old Model T Ford blowouts with a boot. And I think it's really a wonderful adjunct. It'd be interesting to see what the limitations are going to be. We don't know yet the durability of some of these repairs, and that is a concern. Some of these lesions, some of these prostheses may become disconnected and become embolic themselves. But anyway, it is an interesting new technique, and it's based upon a lot of the imaging devices which we now have available, which we did not have in those early days.
Right. I'm interested to read about the mottos and quotes that have been attributed to you, specifically two. The first being the motto of modify, simplify, and apply. How did this happen? How did you come up?
I credit my house staff with thinking up this sort of a slogan.
Right.
And modify, simplify, and apply. I always tried to simplify techniques. I thought new innovations, that's redundant, innovations all seem so complex. You take the early cardiopulmonary bypass, big console and all that sort of thing. Why can't we find some simpler way of accomplishing cardiopulmonary bypass?
And you did.
Yeah, yeah. I think that was one of my contributions, was simplifying cardiopulmonary bypass. But anyway, I like that slogan, and
I think it's terrific.
And the last thing on there is say apply. We would be always with the interest of applying it clinically, not just something to do in the laboratory.
Another quote that's been attributed to you is the statement that a few achieve success through luck, but I believe the harder one works, the luckier he becomes. Is that your quote?
Yes. Yeah, I like that. Yeah.
I think you've always been attributed to exhibiting a very strong work ethic, and despite the fact that you had such technical gifts, you were able to expand that through simple hard work.
Yeah, I think so. My focus, my priority has always been my practice. It even came ahead of family responsibilities at times. I thought that a physician's job, his principal focus, should be on his patients, and maybe even make everything else secondary.
Another area in which you've been renowned is the fact that you were so calm and cool in the operating room. Is this a result of your experience with Dr. Blaylock's small voice?
Well, I've always admired certain surgeons who were very calm and collected and so forth in the operating room. And Dr. Blaylock was sort of temperamental, and so was Brock, and especially Mike DeBakey. And I determined then that I would have a better conduct and behavior myself in the operating room.
This positive environment that you created when you established Texas Heart, is this how you attracted such a spectacular team? Grady Hallman, George Rule, Fraser, Bloodwell. Do you attribute that positive environment?
Well, many of these individuals began their experience in Houston on the Blaylock service, on the Baylor service, and I've always thought that most of them were renegades from Mike DeBakey's program.
Well, I would have to give you credit, though, for establishing a very...
Yeah, the atmosphere has always been
Yes.
much more pleasant in our operating rooms.
Speaking about, in a more political point of view, do you have concerns for the direction of medical care in the United States now?
Well, that's a difficult question to answer properly. You know, when I spent that year in London with Brock, and that was one of the early years of the National Health Service, the one thing that impressed me was that people liked the service. Even there were some qualifications of it at the time. At least patients were able to get basic health care. Now, even then, it was being rationed because you had the wealthier element and the service group. But it's always seemed to me that we ought not deny people access to basic health needs just because of the inability to pay. So I think if we're going to be humanitarian in our position as physicians, we ought to be willing to accept the fact that we have to take care of the poor.
Recently, the Methodist Hospital, speaking of politics, recently the Methodist Hospital has become affiliated with Cornell. Do you think this is a good long-term marriage or long-distance marriage, or what are your thoughts?
Well, you know, Methodist and Baylor were colleagues or associates for 50 years, and then they come along with a few political differences and some monetary considerations and decided to have a separation. And I just thought it was like a long-term marriage that ended up in divorce. It's always a mistake to do that, and I think it was a mistake for them to separate. And since then, Baylor has been invited to be at St. Luke's Hospital for their graduate training, along with other hospitals in the city of Houston. But Methodist needs an academic affiliation, and they went all the way up to Cornell University, which is about 2,000 miles away. It's not a very satisfactory situation. I think that what we need to do in our medical center is to get closer together and maybe Baylor and St. Luke's and Children's and Methodist will get back together from an academic standpoint.
Looking back on the mentors that you've had, Dr. Blaylock, Dr. Brock, Dr. DeBakey, who influenced you the most and why?
Well, that's difficult to say. I think that Blaylock was sort of my hero because of his personality. But Mike DeBakey was another real stimulant to me because of his work ethic and his brilliant mind that Mike has. And he's just a wonderful sort of an icon in cardiovascular, particularly in vascular surgery. But I've been very fortunate to have those three, from Blaylock to Brock to DeBakey, as my mentors.
Spectacular. Spectacular. If you had to give advice to young surgeons coming along now, what would you tell them?
Well, I tell them that times will change and so forth, but there'll always be a need for skillful surgery in the future. And although they may find alternatives to some of the procedures which we consider standard surgical practice today, they may find alternatives for it, but there'll always be a need for skillful surgery. And it's a challenging opportunity, and with all of the new diagnostic facilities at hand, a surgeon can now go into the operating room with feeling of confidence that he knows what his objective is and how to accomplish it and so on. Looking back on those early days when we started doing surgery for vascular and cardiac disease, somebody said in those days our policy was ready, fire, aim. Anyway, it's times have changed a great deal, and I think that the opportunities are still there, and I encourage anyone who is interested or challenged by the specialty of surgery should undertake the training.
Dr. Cooley, thank you so much for this interview.
Thank you, Roger. My pleasure.